sharing experiences, really important, learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scanner.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
Thank you very much. So it's a pleasure to be here with you this afternoon, and thank you very much for the invitation to be here. So as Matty's just mentioned, this session's for you. So you have the opportunity to ask questions, and so I want to try and get through some of the bits that have been in the back of my mind as I've put the slides together, but actually for you to have the opportunity to ask questions that you think are relevant or answers that you're looking for. So I might be a little provocative, but to me, when it comes to cardiology, particularly in inherited conditions, if you don't ask, you don't get. So this session's about accessing the best care. And to me, best care means quality care that's accessible from wherever you are, rather than via a postcode lottery. So let's hope by the end of this session that you can all access the care that you need to meet your requirements. So these are some of the questions that I was brainstorming with Adrian, actually, to try and think, what are the key things that crop up for you when people contact Cardiomyopathy UK? So we'll talk through a little bit about what an ICC specialist centre is and how it's different to a general hospital or a general cardiology clinic. What role should a patient play in this? What is an expert patient and how can they contribute to their healthcare journey? The reason I'd like to touch on that is because I want everyone to really take control of their health because it's your body and your life, and if you're not in control of it, no one else will be. Then just to talk you briefly through how to get a referral to a specialist centre and is it necessary, how you should prepare for your appointment, how to advocate a little bit for yourself and to which questions you should ask, and then to think a little bit about what is an optimal health journey. Is it normal to have ups and downs in cardiomyopathy? What happens if things go wrong? How do you try and get things back on track and how to complain? And then if we have time to touch a little bit on just the pros and cons of public versus NHS private healthcare. So first of all, so what is a specialist centre and how is this different? Maybe if I could have a show of hands, of those of you in the room that are under a cardiology for a heart muscle disease, how many of you are seen in a specialist service? Maybe let's have a show of hands. Okay. So that's great. And I guess, actually, I'll save that one for a little bit down the line, for being too provocative early on. But basically, the idea of having this specialist centre is to really ensure that you get access to the quality care and the expertise that really matters so that your diagnosis is clear, it's well-defined, and it's almost specific, disease-specific, because heart failure isn't a diagnosis. It doesn't tell us what the cause of the condition is. But in cardiomyopathy centres, often it's about really determining what the actual disease problem is. And the aim is to provide you with access to clinical studies or trials, novel therapies that may be coming along as well. And these aren't available in general cardiology clinics generally. But a specialist centre themselves comprises the multidisciplinary team, which will include the cardiologists, geneticists, nurses, genetic counsellors. And this really helps to provide a comprehensive approach to your care and to devise a tailored care plan that works for you. These clinics in a specialist centre also offer genetic testing pretty much routinely and family screening. And again, why is family screening relevant to this pathway? Because we want things to be joined up. If you've got Bob that's seen in Newcastle, Frank who's seen down in Plymouth, how is that information to inform the family, the wider family tree? how is that information going to be integrated? So this is why a specialist clinic is actually really quite important. We have a lot of specialist care policies and protocols. Now we have evidence. So there's the NICE, which is the National Institute of Clinical Excellence guidelines for the UK, but there's nothing specific on cardiomyopathy there. We have the European Society guidelines, of which there were the recent ones, and I'm sure you've heard about some of those already today. But again, these specialist clinics inform their own services to make sure that you get the quality care according to the guideline directive management that you should receive. And the wider multidisciplinary team, including input of psychologists, cardiac rehabilitation, etc., all forms part of this package. How many of you have access to psychology within your specialist inherited condition service? Yeah, so far fewer. It's not commissioned. It's a nightmare to get. We have to fight all the time for it. But again, it's a really critical component. How many of you have heard of IAPT? Yeah, so IAPT is basically psychological therapy support that you can self-refer to nationally. So we have talking spaces. We had talking spaces in Oxfordshire. There are different names according to the area. But if you ever feel that you need input psychologically, you can Google IAPT in your regional centre and it will come up with the contact details for your own referral centre. You can self-refer, your GP could refer you, or a specialist could refer you. So even though psychology access may not be as readily available as we may all wish, it is still there. It's just knowing how to get it. And I've briefly mentioned already about the access to advanced therapies in clinical trials, but there are lots of kind of therapies that are becoming more personalised and disease-specific, and a lot of things on the horizon. So again, watch this space, but the specialist centres are where these elements are going to be. I think you guys are already well equipped with this. What role do you play in this? You have to be centre stage. Everything that happens in that clinic is not for me, is not for any of our nurses or genetic counsellors, it's for you. So if it doesn't work for you, you need to put up your hand and say, this isn't working. And actually try and be brave to say, I need this to work for me, because you are at the centre stage of everything. There's no point, I'm wasted, I shouldn't be in a job if I'm not doing what's right for you. Try and engage as proactively as you can, because at all stages of your care pathway, the whole point of your treatment is to ensure that it meets your requirements and needs. And you may need to gather some specific, I'm very happy to share the slides, so don't worry too much. You can have the PDF or whatever sent through if you're very welcome to it. But gather as much information as you can about your history in the past and about your family history, because that really helps inform us in the clinical team to best guide the family, who may or may not be at risk. We try to put bits of the clinical information together because sometimes it's not clear-cut. So a diagnosis might not be definitively 100% this or 90% that. It may be, well, it could be this, it could be that. We're not quite sure. So we need as much information as we can get together to really inform the clinical picture. So if you can get clinic test results from elsewhere for your family members or their genetic reports from elsewhere, again, bring all of that information. If you've had an MRI scan in one hospital, but then you're seen in another hospital, try and get a copy of the MRI scan. So try and be as proactive in your care as you can and keep a folder of all of this information or it on a memory stick, because it's, again, really helpful to inform your future care. Self-advocacy. Again, your needs, your wants, your desires, your preferences are fundamental. Absolutely critical. How many times does your clinician stop and say, if you were in this scenario, what would you like to happen? If, for example, you had a defibrillator, what would you like to happen in this scenario or this scenario? We've got to understand what your wants, what is it you're looking at? Do you want to live for 50 years less well, or do you want to live and have a really good quality of life? So again, your needs and preferences are critical. And we have to make sure that your needs and preferences align with the goals of the care team, because we can give you tablets. We can try and make you go to rehabilitation, come to this class, come to that class, come to education and training sessions. But actually, if it doesn't align with what your preferences are, then it's irrelevant. Self-management. This is a really key one. Turning up to appointments, yes. Assessing and monitoring your symptoms. So the time when you're in front of a clinician is your kind of one-off snapshot moment. You may have 15 minutes, you may have half an hour to really relay what the issues are, but that's not a lot of time when you then go home and you're not seen for another 12 months or 24 months or 36 months. So keep a log of your symptoms, keep a diary of what's going on, and you can bring that to your appointment. But also try and self-manage your symptoms. So red flag symptoms, chest tightness, breathlessness, waking up from your sleep, gasping for breath, swelling up like a balloon, dizzy spells or blacking out. Those are red flags that you'll all become very well aware of. But if you have these in between appointments, either seek help and go and see your GP or escalate it to your care team, but be aware, become really informed so that you all know your bodies anyway, but if you can detect when there's a problem or where you feel there's a problem, then you ask for help. And if at first you don't succeed, try again. So if you're fobbed off or if you don't get an answer that first time, go back and see the clinician or chase the care team to say, I really need an answer, I need some help here, please can you advise, blah, blah, blah. But self-management is critical because this is your life and your body. But also, follow your treatments, and you may need to make quite significant lifestyle adaptations, reducing alcohol intake, improving your diet, doing the rehabilitation or gentle bits of exercise that are safe to perform on a daily basis to become better conditioned. Education, education, education for yourselves, for the entire care team is absolutely critical because we build up the knowledge gradually. Ask questions to better inform your understanding about your condition so that you can make informed choices. If you don't understand your condition, you're not going to know how to ask the question at the appropriate time. But then if you're at home, you're thinking, oh God, I wish I'd asked that. And I haven't asked that. I forgot to ask that. Keep a notebook and write your questions down. Then when you come to the appointment, you've got them all reeled. I have no problem if someone turns up with 2 A4 sides of paper and says, I'm really sorry, I've got a whole list. No problem. That's what I'm here for. That is my job, to make sure that we can deliver for you. But really, it's really important to understand your condition. How many people have I seen that have been coming to a clinic I was mentioning before? Some people have been coming to the clinic for 20 years, and then they say, well, no one's ever told me I had a cardiomyopathy. And I'm there going, really? Like over that time frame? Why do you think you've been coming? But actually, it's not uncommon. Why? It's well known that people can come to clinic, and the minute you mention something, it's like a drape. It's like the curtains come down, and you can see people switch off. And it's because of the fear. It's because of anxiety related to things. It's the trauma of having a condition. It's that kind of panic mode. Not forgetting you're in a clinic room, and you've got some scary doctor or nurse in front of you. You're kind of in slight panic mode. You are going to forget things. Bring someone along with you to the clinic too, so that you've got a second pair of ears, and jot notes. Never be afraid of jotting notes down. But again, being as prepared and bringing a notebook, but understanding your condition, having your questions so that we can answer them are really important. There are many opportunities for partnerships, and as you've seen outside, Cure Heart and Heart Hive, all of these are opportunities to partner, to learn from each other, and to collaborate both with your care team and with the cardiomyopathy community. And so I think, again, these are elements that you can really participate in research. We're desperate for people to get involved and be a champion, as I can see at least one in this room. Don't forget to feed back on your care. Now, as teams, I'll be 100% honest, I do not recall the last time we sent a questionnaire seeking feedback from people attending our clinics. That's a problem. For me, that's a real problem because we want to ensure that we're delivering the care that you need. So do feedback, do inform on other healthcare services, do compare and contrast, do kind of say, this works, this didn't work, because that's really important to inform and help us improve with our care delivery and services. And shout if things do go wrong or things aren't up to scratch. Say something, because if you don't say anything at all, nothing will change. And it's really important that we continue to change things. Okay, next question is, what's an expert patient and how do they contribute to the healthcare journey? Who's expert in this room? Anyone think they're expert? Yeah? Yeah, you all can be, even if you're not now. A little bit of experience. So where's the difference between a standard versus an expert patient, really? Well, it's everyone with a lived experience and a deep knowledge of their inherited condition. They understand symptoms, the treatment options, and can actively participate. And the aim is to make you all experts so that you can all manage yourselves, that you can all collaborate as you need to, but be aware of the symptoms, the red flags, the concerns that may happen, and think about the treatment options. Being proactive to shape not only your individual management, but also the healthcare pathway and the healthcare delivery more broadly, to ensure that it's patient-centered. This is no longer kind of a paternalistic approach where I dictate what you do. The roles are completely reversed. We need to be coming from you to us now so that we can help support what your wants and desires are and make sure that we cover every angle of your healthcare. So with regards to self-management, an expert takes responsibility day for their health, ensures that they take their medications, ensures they turn up to their clinic appointments. You'd be surprised, 10 to 15% of people don't turn up to a clinic appointment, which means that that's a missed appointment for someone else. Adapting lifestyle, not drinking too much, making sure your cholesterol is low, making sure you are doing little bits of exercise, managing your mental health is really important, monitoring your symptoms. If you're getting dizzy spells and palpitations, what do you need to do about that? An expert also is communicating in an enhanced kind of manner so that you can have more meaningful conversations with your clinical teams to ensure that there's more shared decision-making and personalised care plans according to what you need as well as what your condition needs. Providing peer-to-peer support, mentoring and support for others is not only really rewarding, but it also helps others face challenges and to help them overcome challenges. Even just by providing that supportive listening ear can really make a difference to other people. So encouraging you to take part as an expert, I think, is really helpful for peer-to-peer support. And then actively engage. Ultimately, we want you all to have as good a quality of life with as much independence as is possible. How many people are still looking for a referral? I'm not sure this is going to be a relevant question if everyone's already under a care team already, but how to get a referral, very briefly. Book an appointment through your GP, but make sure you share your family history and unusual symptoms. You can, either the GP can refer you to a cardiologist, a general cardiologist, or a specialist centre. And actually, nearly 3 years ago, I think it is now, I created the AICC website. At the moment, it's open access. So there is a directory of services across the UK, of which there are 38. But if your GP doesn't know where to refer you to for a specialist centre, they can look on the AICC website and get that information. So that's a kind of key signpost. We will be changing it soon so that not all information is available. However, it's a really useful resource. If you require a specialist referral, these are really for complex conditions, often at the point of diagnosis, because it's really helpful for us to devise a care plan at the outset. And then if you're referred back to a district hospital, that's not a problem, because they can follow what the care plan has advised. But often screening the family in the first instance or providing genetic testing, really these sorts of things should be within a specialist service. At the end, if we've got time, we'll think a little bit about the pros and cons of NHS care versus private. But what I would say, the really key message here is if you see someone in the private sector, make sure they're a specialist in inherited conditions, because a lot of general cardiologists will claim that they do inherited conditions, but most do not. So make sure they work in a specialist centre. Otherwise, you'll see them, they'll do a lot of tests, they won't know how to interpret them necessarily in the context, I'm being honest, and then you'll need to be referred on to a specialist down the line. So make sure if you see someone that they are a specialist in the area that you need. Is a referral to a specialist centre necessary? Well, it allows the expertise to be integrated to ensure that you get the correct diagnosis and you get your correct care plan designed, an absolute risk assessment conducted, a tailored care plan, and preventative advice. If you're in a non-specialist centre, they may not be readily available. Moreover, also a specialist centre will often take a more family-orientated approach and ensure that the risk assessment and advice really is provided for the entire family, not just yourself. So they will say, actually, first-degree relatives should be screened. If, depending on genetic testing results, if they've got a clear gene that's causing the problem, they will say, we can test for this, advise that your relatives are referred. If there isn't a clear genetic abnormality, then again, screening with a scan of the heart and an ECG are the key components. But a specialist centre will obviously direct a lot of that. So I would suggest anyone that has an inherited condition or is suspected of having an inherited condition or has a family history of sudden death or first-degree relatives, so immediate relatives, so my brother, my sister, my parents, my children, are seen in a specialist centre once for screening. I think that's actually the ideal kind of situation. One element where you may find that you're rejected from a service is if you're a second-degree relative, i.e. an aunt and uncle. And that's because we want to focus the assessment on the direct relatives to that individual. So we don't want to see every Joe Bloggs in a family, because we want to make sure that we go logically from one step to the next step to the next step, so that A, we don't waste resources, time and effort, but also to ensure that the right people are screened in the appropriate manner, rather than just screening everyone. So if your referral is rejected from a service, it's not because you don't need to be seen, it's not because they don't want to see you, it's purely because it's not following the appropriate strategy of screening those people at highest risk first. So if, however, you don't have a genetic cause of a condition, you may not need to be seen in a specialist centre, and general cardiology may be sufficient. But again, I think it's fair for everyone to be seen once at least in a specialist centre. How do you prepare? Now, again, I'm sure you're all very well equipped with this. Knowing your medical history, gathering your personal records, bringing any information you can, test results, ECGs, MRI scan, genetic testing reports, keep them together and take them to your appointment. Write your symptoms down so you have them there and then, and your family history, which is also really important. And the key things we talk about in the appointment is any relatives with a history of sudden death, anyone with unexplained fainting, anyone that may have had a history of heart failure or stroke in the family, or anyone with a known inherited condition, because those are the key things about relatives that we'll ask about. Please bring your medications and your list of medications with you, because otherwise it's like a lottery for me to pick and choose what someone may or may not be on. And I can't inform or advise on your tablets if I don't even know what you're taking. And unfortunately for us, the computer systems do not work. So I can do my best to try and find out what your medication list may be, but it could take me 5 hours and I probably won't get to the bottom of it. So please always make sure you bring your tablets and your list of tablets with you so that we can advise appropriately on what to do with them if we need to make any changes. Understanding your tablets is also really important. Again, you may need a little bit of time to do so, but again, ask questions. We may well like to ask stuff about lifestyle. So how much do you do exercise-wise? What do you drink? What do you eat? To try and provide a more lifestyle, holistic approach. And really, as I said before, bring a family member if you can. You may require specific tests, so we may recommend that you need to have some additional tests. So don't be afraid if we suddenly say, well, actually, I really want to put you on the treadmill today. I want you to do an exercise test, or I want to stick a heart rhythm monitor. Don't freak out about it. This is standard. It's a routine part of the care pathway. Do take notes and ask about your follow-up appointments. Think about how results may be communicated. Will you get a letter? So quite commonly, when we dictate our clinic letters, it's full of medical jargon. It's because it's not meant for individuals. It's meant for the care team. So it's meant for your general practitioner. So you may well see gobbledygook and not understand it. And again, we can either try and translate it and advise and decipher it for you, or again, ask your nurses who should be part of that specialist clinic. The other thing I would say is that how many of you have a contact point if you run into risk? Let's have a show of hands. So actually, maybe 50-50. So again, we should be doing better. Everyone should have a rapid access line so that 9 to 5 during Monday to Friday, it should be at weekends too, but it won't ever be. But you should be able to phone a friend to say to the nursing team in the hospital, can you please advise on this? And they may not be able to advise there and then, but they will be able to speak to a clinician who will be able to advise. So if you run into difficulties, or if you have questions, or if there are issues, pick up the phone. Do not wait until your next appointment, because something major or a catastrophe could have happened by 12 months' time by the time of your follow-up appointment. So don't be afraid. As I said at the beginning, if you do not ask, you do not get. Okay, how to advocate for yourselves. Who feels in the room that you're good at advocating for yourself? Excellent. So by the end of this, all of us. So again, express your concerns and your fears. Be clear about what it is that you want and bring them up early in the appointment so that these things can be addressed. If you don't understand, say so. Sorry, I'm not following you. Could you explain that in a different way? Sorry, you mentioned this. What exactly does dilated cardiomyopathy mean? Cardio, heart, myo, muscle, pathy, problem. So cardio, heart, myo is all your muscles, pathy is a problem. Like itis is inflammation. So appendicitis or tonsillitis, it's inflammation. So again, ask, clarify. I'm not following. Could you show me that again? Could you walk through that with me again? Could you draw me a diagram of it? Sometimes we'll have a heart and we can draw a picture to say, you know what, this is what it means by hypertrophic cardiomyopathy. This is where the thickness is in your heart muscle. Again, talking people through is really key, but ask, please, please, please. We really want you to ask questions. And ask to clarify any of the treatments or the investigations that you've had. Ultimately, I can prescribe you tablets till I'm blue in the face, but they've all got side effects to someone. So, you need to know the risks, the benefits. Are there any alternatives? Are there any things, cholesterol lowering, for example? We could prescribe statins to everyone, but if some people did a little bit more exercise and had healthier diets, maybe not everyone would need a statin. But some things, and don't forget, some tablets work for some people, but not for others. So again, it's us trying to define what may work. Can you take any information home with you? Everyone nowadays should get a copy of their clinic letter. Who in this room doesn't get a copy of the clinic letter from the appointment? So you don't get a copy of the letter?
It's actually my son, not me, but no. We always used to, and I've got to find about that bit of all these clinical letters.
Gosh.
Echo scans, all the rest of it.
Yeah.
Weeks and 3.
Yeah.
And now, even in our head of clinic and our local hospital, do not get copies, we want anything.
Gosh. So that's just to reiterate for the recording. So, everyone nowadays should be well engaged with their appointments. So if you do not receive clinic letters, then you should ask the service to say, please, can you ensure that we're copied into the clinic letters? Okay. So again, if you're not getting anywhere, you can speak to the clinical team. If you don't get anywhere from that, escalate it to management. And if you don't get anywhere from that, speak to the PALS team, the patient advisory liaison service in a hospital. Oh my goodness, and that hasn't worked. Oh, wow. Oh, gosh. The PALS team is a real trick for under your belt. They're great at often escalating and resolving issues if you really have to take it that far. Okay. So family screening is always a tricky one as well, because knowing how your relatives can get access for genetic testing or screening itself may be important. So again, you can ask during your appointment, how do we go about that? Don't feel pressured to make decisions or to answer questions at the time of the appointment. If you need a bit more time, say, please, could I have a little bit of time? Could I email you, or could I speak with you in a few days' time to go through this? Or could I have a chat with a nurse in a few days' time? If you can't make a decision there and then on something, don't be afraid to say, I just need to digest this a little bit, or can I just go for a little bit of a walk down the corridor and have a think over this? Don't be afraid of doing that. Make sure that you know when you have the follow-up or have the contact information to reach out if you need to with further questions. Raise your concerns or ask. So if you don't know what the lifestyle advice is for you, for example, exercising. So what can I do? What is it safe for me to do? We, again, haven't introduced care plans and exercise plans yet. And certainly we really need to get these much, much better for all cardiomyopathy patients. We've been doing some work with Joy Basu, certainly in Oxford beforehand, to try and see how we can create exercise prescriptions for people. Because as cardiologists, we're really bad at it. And that's why we have experts that can help us try and define care plans and exercise regimes that are safe for people with heart muscle diseases. Think about your emotional and mental health needs and support, because I think, again, there are counselling and support resources, as I've mentioned, the AIPT services, and follow-up and next appointments, I think, is pretty clear. Other bits to think about: if you're concerned that something hasn't been fully addressed, say so. Or I'd like a little bit more information on this, or could you provide me with some links? Because again, we can attach some of these links to the end of clinic letters if needs be, or we'll have patient resources in the clinic appointments that we can provide you with. If you're not happy with your care, you have the right to a second opinion. And so if something sits very uncomfortably with you, do not be afraid of saying, please, because I had a second opinion, I'd like to see another clinician just to walk me through things, or I'm feeling a little bit unconfident or uncomfortable. I'm struggling with this. I'd like a second opinion. And you can do that either to your direct cardiologist specialist team or through your GP. So please, if you feel that you need that, then do not be afraid to ask for it. We've talked about education yourself already and engaging with a healthcare team, so I'm not going to go through that again. But what questions to ask? Well, prepare a list of questions before you go in and try again to think about what you'd like to learn from the appointment. So it may be, what condition do you have? Is it inherited? How did it arise? Why did it occur now? Why is my condition different to my brother's condition if you both have the same? Why is it different in me to him? Why is his much less severe than mine is? Because these things will run through in your head. What tests may you need to confirm a diagnosis, or what tests may I need to have my condition monitored over time? We've talked about lifestyle changes. What's my risk? So calculating risk should be done at every single clinic appointment, and it often is not calculated. So again, just be mindful of, is my risk low risk? Is it medium risk? Is it high risk? What does that mean? What kind of percentage? What numbers? So again, we have risk calculators in the medical profession for trying to help guide risk, but it's very much on a case-by-case basis, and one size doesn't fit all. And just because a calculator says someone's risk is 8% at 5 years, what does that mean? It's again variable. We don't have a crystal ball. What's an optimal journey? Well, I did a bit of brainstorming, and I could do with your help with this too. So to me, it's about creating a proactive, personalised approach that's patient-centred around yourself, around your informed choices, that provides you with effective support and holistic care. So it's about being aware, proactive, self-educating, being self-aware and preventative, setting health goals, a wellness plan, and prioritising balance, ensuring quality care that's respectful and coordinated, engaging with self-management and healthy habits, but also the health literacy, i.e. getting yourself better informed for better decision-making. The mental health and the emotional well-being element for both resilience, support, and long-term balance is key. These are chronic conditions. They don't generally go away. So it's managing that, and you will come up, there will be bumps along the road. An analogy someone mentioned to me the other day: if you're driving down the road and your car breaks down, what do? You don't just get out the car and walk away and leave it, do you? You fix the car, or you get a mechanic in to fix the car, and then you carry on driving it. That's what we all have to do. And even if we are really troubled by a health condition, we have to keep ourselves going. So we come across a barrier, jump over it, rise above it, deal with the blockage, move forward and keep going, and realize that actually you're all hugely resilient to have come through this process so far. Keep going, seek support where you need to. And then that's really where it also builds this support system that's really key. Friends and family, the community resources that may exist, Cardiomyopathy UK charity that exists to really help empower and support yourselves through this journey. We want the journey to be as good as it can be, because ultimately it is about quality, and it's about really making the best of every single day that you have. Maintain motivation and think long-term as well as short-term, because actually with cardiomyopathies nowadays, the risks are so much lower than they've ever been, and we have fantastic therapies, great support, and really what we want to do is to see you all fulfilling your life in the best possible way that you can. Is it normal to have ups? Of course, everyone in life has ups and downs, and just because you may or may not have a chronic condition, it's no different. It's just about adapting to that level, to the kind of the new setting, the new level that you may be at. But again, thinking about all the different elements that may be important. What happens if things go wrong? Well, the best thing to do is to track your symptoms, keep a diary, jot down, are there any triggers to symptoms? What was the build up to that event? If you had say you had a blackout or a faint one day, what happened? What were you doing beforehand? Were you dehydrated? Had you done too much sport? Had it been a really hot day and you'd maybe not had a water bottle carrying around? Had you had a cold or an infection? Had you had a flu jab? Just to really kind of think, what happened around the time that I felt unwell with that? Make sure you follow your care plan, because that will limit the risks as much as possible. Taking the tablets that you're prescribed are really key. But listen to your body. We all know our bodies. And ultimately, you know when something's not right. So listen to your body and take action if it's not right. Do also learn to pace yourself. It's a marathon, not a sprint. And ultimately, we can try and help plan for and then prevent symptom flare-ups over time once you listen to your body. The prior session we had in here there was a lot of talk about menopause and palpitations related to the menopause. These are really common, but it's it's managing it, listening to your body and kind of going, okay, I need to adapt X, Y, and Z in this situation. Stay in touch with your healthcare team and other peers, and make sure you attend your regular checkups, as I mentioned. So briefly, how to complain. So you can complain directly to the doctor or the nurse that you're seeing at the time. You can escalate it more to the management system. Now, having managed a service and been clinical lead of a service for over 7 years, I have dealt with many a kind of minor complaints, many a more major, not major, but formal versus informal complaints. And most things can be nipped in the bud very quickly. And we're really keen to hear, I want to make sure things work best for you. Trying to go informally is by far the easiest, because otherwise I end up with about 20 pages of paperwork to do. So it really makes my day more tricky. But if you can't find your way through a situation, then a formal complaint is often required. As was mentioned by Tracy earlier, we are stretched. Resources are challenged. Systems are not working to the level that they should be working at. So we're trying to do our best, both in the primary and the secondary care setting. But again, we want to work together with you all to really optimize things. If at first you don't succeed, escalate to the PALS team, because they often will. They are the kind of real dynamite of the hospital. To be honest, things get actioned within a couple of weeks normally. And if there's something more major, then again, a formal complaint, even higher up than that, can be required. What about in your GP practice? So there is a practice manager for each GP surgery. So again, you can escalate things to the practice manager. There are some other local councils, even your local MP if things are really troublesome, although I have to say they don't tend to respond. Ultimately, what I would say is the most important thing is to be clear, to be concise, stay calm, be objective, and politely chase them up. Would you be so kind as to provide me with a response to my email dated such and such? Any questions so far? Or should I finish with the private versus public and then we open the floor? Maybe I finish with this bit and then we'll finish. Okay, fine. So just to give you a little bit of the ins and outs of private versus NHS healthcare. As I say, the most important person to see is someone that is an ICC specialist. So no matter who you see in the private setting, make sure they have clinical experience. So with regards to the NHS, pros, there are no direct costs. So you don't get charged for your tests, your consultations, your diagnostics and your treatments. We do have specialist ICC centres. You may not get access to a specialist. You may be seen by a junior doctor that's not necessarily a consultant in that area. Now, often the juniors will liaise with the doctors, but you're not going to be guaranteed to see a consultant every time on the NHS. But within an ICC centre that you should have experience from specialists. There is access to comprehensive family screening plans and actually also pregnancy-related plans for inherited conditions too on the NHS now. We do have the real benefit of integrated care records. So when I write, it's all documented on the system. Yes, that system may not link up from, say, London through to Birmingham, but there is a means, there is a record of it that is accessible. That doesn't happen actually in private healthcare. It's more someone's letters are stored somewhere independently and there's no kind of often log or documentation more widely. So there isn't a kind of solid repository for all of this information. Clinical trials and research are a really key thing within the NHS because that is open forum, particularly with hospitals that are attached to an academic unit. That again is something you don't get in the private sector. But the cons, you're all well aware. Everyone in this room has, I'm sure, waited over 12 months for an appointment. Long waiting times for everything. Limited access to some treatments. So sometimes things aren't available on the NHS. There may be funding requirements or we may have specific approval constraints. So I may have to write an application for someone, say, from the South Coast to have a treatment or to come and see me in London because there's an issue, postcode lottery issue. Flexibility is also more limited. Rigid appointment times, we unfortunately have to be less accommodating and my managers will scream and shout at me if I don't hurry up and see patients more quickly in my clinic. So I take that, and my clinics will overrun, but that's because I want to ensure that you get the best appointment during the time that you're actually there. So apologies if you do have to wait. I would say that in the NHS there's also a less personalised experience. What about in the private setting? Well, you don't have the long waiting times. You'd still have access to many of the specialist tests, including genetic testing. But again, make sure that you're seen by an ICC specialist to ensure that you get appropriate genetic counselling before and the appropriate advice following your genetic testing. Flexible appointments, much easier in the private sector. And you get to spend a lot more time during a consultation with a private specialist. And you get to choose who you see. As I say, see an ICC specialist. But the cost is much higher. You have to pay for everything, whether it be the genetic tests, whether it be the consultation, the diagnostic test, the follow-ups, every phone call you make, every email you send, you could be charged for. Insurance doesn't always cover things, particularly for inherited conditions. So insurance doesn't necessarily cover genetic testing. It doesn't necessarily cover more than one cardiac MRI scan. And they don't like follow-up for chronic conditions. So you may be able to have your diagnosis, but once you've had a diagnosis, often insurers will not pay for you to be seen downwind. So they'll get your diagnosis, but then after that, they'll say, I'm not covering you for this chronic condition. So be aware of that. Also, we have very limited access to discuss complex cases. So in the NHS, we have meetings every week where we will discuss a really complex case to say, between us, oh, what do you think we should do? Should we do this? What are your thoughts? What are your thoughts? So we have a room of specialists and we talk through the best management plan. That doesn't happen in the private sector unless the clinician takes it to an NHS MDT, multidisciplinary team meeting. And again, as I've mentioned, there are no integrated records, and so it's very fragmented in the private sector and very limited access to research or clinical trials. Which option is better? It's down to you. It's down to your preference, really. Personally, I don't think you can get better care for inherited conditions than on the NHS because it's very fragmented. But often what people do, particularly if the waiting times are very long, they'll see someone in the private sector and then transfer their care to the NHS for chronic management. And that does tend to work. But if that is the case, make sure that you provide all your letters from your private assessment to your NHS doctor because they can scan them and upload them onto the system so that they're all documented there. And we're likely to ask for copies of the scans that you've had so that we can see them and make our own opinion and judgment of them. So that's really the bit that I wanted to go through. And I'd really like to open the floor because ultimately, this is for you. What are your questions? Let's open the floor to questions and comments. Please do ask whatever you like.
So, thank you.
Let's hope I word it properly. I think it's sometimes because there's a lot of information to learn quickly, like medicines, for example, and some are like, for example, ACE inhibitors versus ARNIs. Mm-hmm. And I could have got it wrong that ARNIs are a little bit better, but there's a criteria for getting an ARNI, mm-hmm. and you're often on the ACE for a while, and you're bound to get better. And it's like, do you therefore miss out on the more superior medication because that first medication has done quite a good job and has 2 points taken you over the criteria? So it's like, how do you start a conversation with your cardiologist, whereby you want to think longer term, be on the best medicine for you, but you're almost waiting for a no, but trying to convince him it should be a yes. How do you approach that?
So you're completely right. So these are treatments for impaired heart muscle function. Traditionally, we used ACE inhibitors, but when the ARNI family of medications came along, we could see that there was a 20% improvement in basically hospital admissions and symptoms, etc., adverse outcomes with an ARNI. The challenge that we've got is that if your ejection fraction is even 1% above, say, 40, you're not eligible to get an ARNI because of cost. So most of things in the UK come down to cost. So the reason they won't be upgrading it is because they'll fudge it to say, well, actually your ejection fraction is too good to get it now. But that's because it's a bit more expensive to provide it. Personally, I prescribe ARNI very readily. I will often give a very brief trial of, actually I tend not to use the ACE inhibitors because we have to withdraw them for 48 hours before starting an ARNI. So what I tend to do is use a different type called an ARB because then I can just switch straight to an ARNI. That's because our guidelines suggest you have to try the ACE or the ARB first before you can go to ARNI. It's inefficient. A lot of the recent evidence that's been produced has shown that rapid up titration of these medications is the really key parameter that reduces morbidity and mortality, i.e. Improvements in health. So I would say, well, okay, so you've mentioned the ejection fractions maybe a little bit higher than 40, but my baseline was lower. And I know that this medication is going to benefit me, my adverse outcome in a much better way. And say, actually, I've got many friends that are also taking this medication. They do very well with it. My understanding is it's better for my condition in the long term. Something that, as has been mentioned, isn't very well done in the NHS is prevention. Prevention is better than a cure. Getting onto the best medications, the highest quality evidence-based medicines is so important. If you irritate people enough, they'll give in. Sorry, it is true.
Cheers, thanks.
So I live in North Yorkshire. I'm not with a specialist integrated care centre, unfortunately. I think my nearest one is Leeds. But obviously I'm concerned that's outside my catchment area. Am I likely to be accepted? And how do I mean, my cardiologist is lovely. So I'm a bit like, do I leave him and go to a specialist care? But although I think maybe I should. How do I go about making sure that if I approach him about it, I'm actually going to get in rather than upsetting him and then... Does that make sense?
Yeah, no, absolutely. So ordinarily people will not reject any referral to the service. The only time is if there is another specialist centre within that area that's closer to you. So if Leeds is your main centre, then Leeds are not going to reject you. So for example, sometimes if, say, the barrier between London and, say, Oxfordshire, where we've had management come down to us is to say, well, you shouldn't be seeing the people from Milton Keynes, or you shouldn't be seeing the people from this bit of the pathway. As a clinician triaging, the only time I've ever rejected a referral is if it's been a second-degree relative, i.e. someone that's so distant a relative that we shouldn't be screening them, certainly in a specialist centre. But otherwise, you shouldn't be rejected. Asked to be referred, you actually have a right in the UK to be referred to any specialist you wish to be referred to, even if you were living in Manchester and you wanted to come to see me, you'd be allowed to. You are allowed to choose who you see.
Thank you.
Any more questions?
Well, I've got one. I'm quite a fan of the idea of an NHS app carrying my records. And I discovered by looking at my records that they don't really. And that I was required to sign a form that was built in 2015 to give permission for back, and it won't go very far back, and I understand that. But I wanted to get my heart condition detailed on the NHS app. Would a clinician ever look at patients' NHS app if they showed it to them? Because travelling around the place like I do, you don't often... Anyway, that was the question.
No, absolutely. So, yeah, the NHS app hasn't quite reached its design trajectory. Like, it hasn't really become what it was supposed to be. But actually having an NHS passport, almost as though it maintains all of your records, I think is critical. I would think it unlikely that doctors or nurses in a service wouldn't look at it. I mean, to be honest, if someone had access to their bloods, please do provide them. Because if I'm in clinic and I need to repeat someone's bloods to know whether I can alter their medications, if they've got a copy of their recent blood test performed by their GP and they can show it to me, fantastic. I need to see the evidence. I can't make any clinical decisions based on a verbal. But if you've got the information, absolutely. And if any of it can be uploaded. I haven't mentioned, but I do have perhaps not a disclosure, but something that, so for example, I am actually co-founding a tech company to try and help provide support for patients and to help support up titration, optimization and monitoring in the remote setting, as well as managing preventative elements, because again, prevention is better than a cure, but also to contain care plans so that people know what they're doing, and it engages with quality of life questionnaires, etc. Partly so that we can really tackle the whole part of the care pathway that needs to be tackled, but really that is going to entail engaging with populations and communities like yourselves to see whether it works well for you, because ultimately we want to design something that works for you. But if you're not in your clinic appointment, it would say, for example, have you had any breathlessness today? Have you had this or this? What tablets are you on? Has it changed? Any side effects? So it kind of allows you to have that almost remote support doctor. It's like a hand being held. So if you've come into hospital, you'd get discharged home with it, for example, and then it would provide you with that kind of AI stroke avatar kind of person in the background that's holding your hand in a remote setting. And if there are red flags that crop up, so if you put input data and it kind of goes, ooh, then it's going to say, actually, that's a symptom you need to be aware of. You need to see someone for that. So it will help support you a little bit. But I think that's ideally where the NHS app would have gotten to. I don't see it getting there yet, although there is still a lot of work ongoing in the background about it.
Thank you. It's always the person at the back, isn't it? Yeah.
Trying to get you fit.
I was fascinated to hear your description about good patients complaining.
Mm.
And I suspect I'm not the only person in this room that struggles with complaining.
Mm-hmm.
But I just wanted to kind of think that through a bit with you.
Yep.
It doesn't just benefit the complainant, the person who's complaining, but it also benefits the healthcare provider, because then they think about what we're doing wrong, and then that benefits
everyone else. Mm-hmm. Completely.
I mean, as you talk about all the paperwork you have to go through and stuff like that, you still think it's worthwhile?
Absolutely. I mean, okay, maybe it comes back to me having been governance lead for a long time. For me, if I cannot deliver a good quality service that meets people's requirements and expectations, then we're not doing a good enough job. So I take it very proactively, and actually it really helps us inform our services. Now, not all hospitals are like that. Not all clinicians or service providers are like that. But I think it helps inform everyone. It's all about learning. It's all about growing. It's all about improvement. And if you don't know what your baseline is, or you don't know where the challenges or the issues are, how can you possibly improve them? So I'm very open door for this kind of discussion, because ultimately, we're all taxpayers. We're all paying for our NHS services. We need to get it as good as it can be, albeit within the limited constraints that we're working within. So yes, absolutely.
We've got time for just a couple of quick questions. Thank you. There we go. Thank you.
I just want to mention something, how to get to letters and documents from hospital. Something called subject access request under the data protection law. That's one email to the data officer of a hospital. They have 21 days to respond, and they must send you the letter.
Yeah, so that is another law unto itself, subject access requests. So again, I guess the question is why? So to me, the reason for doing that is if there's some kind of issue, or there's something that's cropped up within your care that's not what it should be, and you might want to gather a little bit of evidence to see what's going on. So that's the purpose of a subject access request. It's not for asking for a copy of your recent clinic letters or your echo report or whatever else. Personally, I think that all of these documents should be available and open access, so that you don't, there's no point me doing a scan in one hospital and you have an appointment, or you get admitted at the other end of the country and then they do another scan 2 weeks later. There's just no need. So if everyone could have access to the reports, that would be best. In an ideal world, I would have a printer in my office and I would just press print and give you a copy of the echo report and a copy of your ECG. Oh, that's the other thing. Never be afraid of asking to take a photo or a scan of your ECG when you're there, or even a scan of the report or the picture, because actually it's your data. You take control and have your data. Okay? Never be afraid to ask.
It's not a question, but it's carrying on from what you've just said, is that I have copies of all my clinic letters and ECGs on my phone.
Mm-hmm. Yeah.
And it does come in handy, because when I've ended up in A&E, and I once ended up in A&E in Leeds, and I could show, and I'm from Sheffield, so I could show them my last clinic letter and my ICD information, and it was very useful.
Makes a huge
Yeah.
difference. Otherwise, it's guesswork. And you know, I mean, it took me many years to learn the language of medicine. I mean, many years. We're not expecting you to know, now how do I spell that again? And what was the name of that? And I can't quite remember that. But actually, that's why just just keep a copy, and then you don't have to worry about it. And the medics will kind of go, oh yeah, fantastic, this is brilliant. Because otherwise it's complete guesswork. If you go into hospital having had, I don't know, a blackout, or you've been swelling up or developing some heart failure symptoms in a place that's out with your normal home patch, that care team will take hours trying to understand the condition, trying to get some information from your local hospital. It really improves the care. It makes it so much more efficient and effective. So definitely take as much as you can and keep it electronically, keep it in a file electronically so that you have it at your fingertips all the time. It's so key. And also, for example, if you get admitted to a hospital with some chest pain, which is not uncommon in cardiomyopathy, I would like to see what an ECG was before compared to the one when you're admitted. And so if you've got a historic copy of an ECG, it's really helpful, because I can compare like to like and go, actually, that's completely the same as before. That's helpful, that's reassuring. Whereas if it's very different, I'm kind of going, okay, we need to look further here. So it's really helpful.
And just going back to the point you touched on between public and private healthcare, are you saying the best way to get seen by GP is by going private and then getting referred to your ICC specialist?
So you see your GP, you have to see your GP to seek any referral. So if you want to be referred to a private specialist, then you still have to get a referral from your GP to be referred to either the NHS or the private setting. So your GP is the gatekeeper for all of this. In an ideal world, we would get rid of the GP bit and you would have direct to service access, i.e. you could request to be seen in London, say in Imperial or Guy's and St Thomas's.
So my partner was quite ill just over a week ago. She started having chest pain. She's got DCM. And when she went onto the app for a local GP, it said that the next appointment was the 4th of December. So and then their response to that is, we'll go to A&E.
Yeah.
And last winter we went to A&E because she had a virus. We were in A&E for 22 hours. So it's just, we feel like we're stuck now, which is why I brought up, can I pay privately?
You can pay.
And go straight to a private GP to skip to NHS GP and then go, because she's already registered at the ICC at Basildon.
Yeah.
So she has a cardiologist specialist at the ICC in Basildon.
So yes, you can see a private GP and then they can refer you wherever. What I would say, if she's already under a clinical team, she should, well, for starters, if she's got chest pain and there's concerns with regards to the chest pain, she might need blood test and an acute assessment to make sure that there's not something really worrying. But again, phoning your local care team and escalating it to your care provider, because picking up the phone to the nurses and phoning if you can't get through initially, that's really key. And dropping an email through to the local service is also helpful, because at least that way you've provided documentation. Again, putting something in writing is quite helpful, actually. Yeah.
Eleanor, we're coming to the end of your session. Thank you so much for your passion and commitment to the client, the patients advocating for their own. So it's good. Can we acknowledge that?
Thank you all.